I'm the Executive Director of the Washington Health Alliance. It's my pleasure to welcome you to our Performance Measures Coordinating Committee and to thank you on this beautiful, beautiful summer day for spending a little bit of time with us. So I'm going to take you through just a few housekeeping items here to kick us off. Please silence all electronics, and although there's no formal break, we have snacks in the room. Please enjoy. Restrooms out the door to your left, down the long hall, and then to the right if you need to take a break. This is a public process. We're very committed in this committee, as we've been in every session, to maintaining a transparent and open process. It's very important. There will be time for public comments. These meetings are open to the public, and we'll introduce some guests in the room today and perhaps some on the phone as well. There'll be time on the agenda for public comment prior to any action on measures, and all of these documents will be posted on the Healthier Washington website really quickly after this meeting, and the Healthcare Authority welcomes comments at any time, as does the Alliance. So today's objectives are to finalize advice on the Performance Measures Coordinating Committee purpose and role statements. This is a carryover from a conversation with the committee at our last meeting. To review plans for membership of this committee and to seek the committee's advice, another action step from the last time we were together. We'll be looking at measures appropriate for contracting, and we're really pleased to have some health plan leaders in the room with us today and more to come to engage with us, and we thank you for helping us with the survey document you spent time and energy preparing. And our real goal today is to get through some of the business so we can have a conversation with our health plan leaders. Do we have time for around the table introduction? Yes. Why don't we do that?
We may need to do it again at the 3 o'clock session with health plan folks here.
Okay. So John, I'm going to start with you. We'll work our way around the table, okay?
Hi, I'm John Francis. I'm the Vice President of Network Strategy for Kaiser Permanente Day. Just joined them in December, so I'm still relatively new, but thanks for the invite.
Welcome.
I'm Susie McDonald from Quality at Washington. I've been there for group health for 38 years.
we average up to 15 years.
That's good.
I'm David Wilson, the Medical Director of Premier Blue Cross. I'm here for the part later on in the meeting, and Ken Jesler, who's our Vice President of Quality, is on his way.
Great. Thank you. Welcome. Kathy.
I'm Kathy Lopey. I'm from the Department of Health. Marie Dunn. I'm VP for Quality and Safety Initiatives at Public Health.
And the new members. We welcome you.
Taking Jonathan Sugarman's place. He's probably happily off climbing mountains by now.
I think that's true.
I'm Susie Day with Washington Health Alliance.
And Dan Leffler with the Healthcare Authority.
Torney Smith, Spokane Regional Health District. Good afternoon, Rick Rubin with One Health Board.
Gail Reisner, representing Washington State Medical Association. Laura Finnington, Healthcare Authority. Ella Jane, Healthcare Authority.
And in the room?
I'm Breland Young. I'm with GSK Vaccine.
Bob Brenner with the State Medical Association.
And on the phone?
Elia, are you on mute?
And Lori?
Here, but has not put in her audio.
Okay, so Lori here with Oregon Health Sciences University, Jennifer Graves with the State Hospital Association, and Elia Moore with the Olympic Community of Health, all on the phone.
Welcome, everybody. Okay, Dan.
So we want to pick up where we left off, which was just on the purpose and goal of the committee. And people will recall the last meeting we had actually a really good conversation about sort of a draft of purpose and goals that was reviewed. And there were suggestions that were made, and you know, I would say those have now been digested and incorporated here. So we just wanted to reflect this back, thinking that this really sort of represents the consensus of the group. And I suppose it might be easiest if I read the top 2 bullets, and then maybe people can look, and you've got the handout as well, sort of the finer print on this and the next slide. So the purpose of the PMCC is to identify and recommend the Washington State Common Measure Set on healthcare quality and cost for monitoring population health status and healthcare delivery system performance on key measures of quality and cost. Intended use of the Common Measure Set may be both narrowly defined and broadly defined as follows. And on the narrow side, you can see we're talking about stakeholder input, and here it's for, as a state as leader of Healthier Washington as a purchaser of healthcare, so this is really, supporting the state in its efforts, I would say. Stakeholder input to validate and endorse measures of focus. Selected measures provide focus for state healthcare contracting. Selected measures provide focus for state health improvement initiatives. And then on sort of the broader role for non-state public and private purchasers and payers, stakeholders' input to validate and endorse measures of focus. Selected measures provide focus for statewide public reporting, e.g. the community checkup, and then selected measures recommended as a line platform for public and private payers, purchaser contracting. So, and then I believe on the next slide is a bit more detail as to the role of the PMCC. And I think it's really, this is, I would say this is the slide and language that captures the conversation and where there's been some modification based on that input. And so I'm trying to find the one.
Number one.
Yeah.
Sub-bullet one under number one is where we spent most of the time.
Right. So the PMCC is responsible for annually reviewing and recommending measures for the Common Measure Set. To fulfill this role, the PMCC must, one, take into consideration who is using the approved measures and the qualitative impact of having the Common Measure Set in place. And really here, the idea was that the PMCC won't, formally evaluate the impact of the measures on or quality of care, but can qualitatively, in terms of the people around the table, bring sort of the perception to bear on whether or not there should be modifications or changes to the measure set. So I think it's recognizing the need to be sort of cognizant of how the measure set is playing out, in the broader community in a qualitative way, and bringing that to bear in terms of the deliberations here and changes to the Common Measure Set. I think that's where we've landed. So
this was an addition. So in the last draft, that point wasn't there, and we spent a lot of time talking about that. So this is how we modified the statement.
So,
And do you want to do out of scope?
right, yeah, and then, okay, so, right, and then, so out of scope, and actually this is what I was looking for the number 4 here, the notion of formally evaluating the impact of the Common Measure Set, but also out of scope is establishing performance targets for national benchmarks don't exist, sponsoring and leading specific quality and improvement initiatives, and assuming responsibility for incorporating measures into contract. And again, I think the 4th point here was the one where there was considerable conversation about distinguishing between sort of the qualitative input that individuals bring to the table versus formal evaluation of impact. So with that, see if there's any comment, Rick. Yeah.
I want to thank you for those additions. I think that really does reflect a lot of the conversations that occurred around the table and occurred around the table in the past. And I think you've made an important distinction between sort of a rigorous scientific study of the entire impact of all of this and the ability to assess where things are working and the question of burden and numbers of measures. So I very much appreciate that change. I think it'll be interesting to talk about, how we do that kind of group going forward, but I really appreciate that modification. I guess I had one other question, and that that's on the roll when you come down to number 3, and we talk about promotion of the, on the handout, it's number 3 under roll. And maybe part of that relates to the conversation we'll have later this afternoon with Representative Elfman. But that, it's always just been a little unclear to me how, as a committee, we play that role. I understand that part of the purpose of having people on the committee is hopefully they would advocate within their organizations. But I wasn't sure whether you were also thinking about any type of, for want of a better term, marketing, outreach, sort of organized promotion effort. That's just a question. I think it's good that that's on there, but I think it might be interesting to talk about, and again, maybe this afternoon's conversation is where that starts.
Well, I think it's, and I think it's where it starts. I mean, I don't, and to the extent that the last meeting sort of led to the conversation today, I think it's an example of how I would think of promoting. And so Marguerite.
She's on the phone.
Okay. Thanks. Have a comment or just?
No, she's just joined.
Okay. But I don't, I wouldn't envision us having, sort of more formal marketing. I mean, I think it's, it's more trying to have a place where you convene to have the conversation. You try to get the right people around the table, and hopefully convince them of the value of moving toward, a common set of measures. And I don't know if others have other thoughts, but that's a good question.
Thanks.
Any other comment? And Rick, I appreciate the feedback and actually want to recognize Susie's work in terms of actually sort of adjusting and incorporating into language.
I just had one kind of question. I recently saw an article about somebody who had applied a set of criteria to actually evaluate measures. I don't know how commonly that's done. They went through a lot of math measures, but I'm just wondering if that's something that we should be paying attention to. I don't know how reliable their criteria were that they used.
Can you send me the?
Yeah, I will. I'll send it. I didn't even know it exists, that somebody was out there actually evaluating the metrics.
Measuring the measures.
Right. Where was it out of? I'll send it to you guys. It was in the New England Journal of Medicine, and I think it was short. It was in their policies digest that I get. I don't know if you saw that.
Steve Kerr just spoke at the High Corps meeting last week. The Hutchinson Institute for Cancer Outcomes Research, they just released their report a week ago.
Okay.
On quality and cost, and she was one of the speakers, and she talked about evaluating measures.
Okay.
Yeah.
So this is a newer emerging.
It'd still be helpful if you sent me the article. Yeah.
All right, so why don't we move on? The next topic we just want to touch base on is membership.
Sorry.
And I think what we want to make sure is that we have the right people around the table, and there's a commitment to participate. And there, over time, I think everybody has noticed, and we did talk a little bit about this last time as well, that that attendance has declined, and so it's really trying to look at the roster of people and and ensure their commitment and make sure we've got the right people around the table most of the time. So we've done some work reaching out to people who have chosen not to continue, but reaching out to still some others to confirm their commitment, and we've actually added some members to broaden our representation representation, and that's what's noted on this slide. And I'm wondering, Susie, if you have anything else to add?
Well, I actually went back and looked at attendance for the last few years and created, kind of a crosswalk of who's been here and who hasn't, how often, and, my recommendation to the healthcare authority is that we, check in with those people who never show up and ask them to either start to participate or agree with them that we're going to remove them from the membership roster and that we would look for others to fulfill those membership categories. So the legislation calls out, the legislation that created this body calls out some, kind of broad categories. And we need, HCA is still in the process of contacting the 6 people that are listed on the note that I sent out. So that's Craig Blackmore, Ann Christian, Patrick Connor, Ann Hirsch, Carla Reyes, and Caitlin Stafford, to find out they're the ones that where attendance has been low, and we want to see if they want to continue or move on. I think we really would benefit from having somebody from a large employer and a small employer to keep the purchaser perspective here in the room. We have some insurers at the table, and we would love to round out membership from all of them, including the commercials and the Medicaid MCOs, so that we really have full representation from the health plan, given that we're looking to them to be one of the primary vehicles for using the common measure set in contracting. Because United Healthcare serves as both a MCO and a commercial insurer, we'd probably just seek one person from their shop rather than 2. But that's the plan, and I think we just really wanted to hear from those of you in the room whether that process kind of makes sense to you. Do you think it's fair to sort of ask, to remove people from the roster if they're not really part? I mean, there's no expectation you're going to be at every single meeting, but, when you've missed every meeting the last 2 years, there's probably a lack of interest, and, I think we would be well served to have people in the room who actually really are interested in this work and moving it forward. So that's the concept.
I just was going to add, Francis Goff from Molina has joined the line on the line as well.
I think if you have the opportunity to interview people and find out why they're not participating, that can be really valuable. So sometimes somebody thinks it's a great idea, but they're the wrong person.
Right.
Sometimes they think they're the right person, they think it's a bad idea. And those you really want to understand. If you have the right person who doesn't find it useful, you really want to understand why they don't. If you have the wrong person, use a different person. I guess one other question that comes up is, if you think of some of the large organizations around the table and the differences of functions within some of your large organizations between somebody who's really the measurement expert and somebody who's focused on applying that measurement in your daily work, and somebody whose job it might be to try and drive those measures into a contracting process, those could be very different people.
Right. And I think we need a mix of those people around this table.
Yeah, and that may be, and I can envision someone who's focused on the contracting side of it, maybe struggling at times to participate in the conversation about the gory details of the measures. So,
It'll be gory mess.
Oh, very much. That's good. I think that, sometimes I think groups that do that sometimes get a certain amount of work done through committees, and I know you've subcommittees in the past, but that's one way of reconciling sort of those very different functions of those people. I do think if you look at our role and purpose, you've got some different skill sets that within, I'm thinking of some of you guys, and so that's just another observation, that surveying people as to why they're not participating, and perhaps people who do attend regularly, what do they find fulfilling and why is it their time, and then thinking about, those different roles.
Yeah.
So the other thing, yeah, I agree with you. The other thing is, as I recall, when we first signed up, how regular was it? Many of us were here from the very beginning. But when we first signed up, it seemed like, I don't remember exactly, but I think we expected to do this for a couple of years, and, until we get a measure set, developing and continuing. So the other piece make sure you have the right people in the room and do, and different roles. Content areas isn't done, but something to get about, are you still willing to represent KB Washington? They still feel comfortable having me, represent them to be, this many meetings. Are you in or out? Because then that happen anymore. I just keep coming, but I think that, and you got to read up again. You can just a little lazy because you're going, and then, maybe I could skip a couple, and then you get out of it. So I think that's okay too. And if you're not ready to commit to that, then you find someone else.
So I would just add, along that same line, that to check with the organizations that those people were representing, and ensure that the organizations not know that they're coming.
Yeah, well, that's true too.
Yeah, and really have somebody that they would like to send in their stead.
So most people are here, were appointed not so much to represent group.
Mm-hmm.
You're different.
I guess that is a very important.
Yes, really here to represent Virginia Mason, who's really here to be a. So, what we're suggesting, we actually identify specific representatives from the health plan, and then make sure we have representatives from each of the commercial and MCOs in the state, but then make sure we have the stakeholder groups that are noted in the legislation covered as well. So this is all good feedback.
One of the opportunities also, I think, particularly when you have people with different skill sets, there's an educational that I think, I am not a measurement expert in a lot of the stuff. I learned a lot listening to the conversation last time about some of the PDMP stuff. We actually moved the PDMP data, and I learned a lot about some of the aspects of what goes on that I wouldn't otherwise have known. And I think similarly, there are probably people who spend a lot of time mucking around the measures who may not be as aware of the burden of people collecting that data or the challenges the contracting people have. So I think the committee could also be an interesting place to not just talk about the measures, but also to talk about some of those other disciplines and help inform all of us.
And I would add to that we've had this discussion on and off since the metrics were, brought together in the first place, and there were a lot of providers involved in. And we keep coming back to this is really looking at regions and looking at plans and looking at communities. But in fact, it's the boots on the ground providers that potentially are going to be impacted as these all get put into place. And there are metrics that we're all responsible for that are national, and that are specialty, and that are hospital, and that are, KP related, maybe performance metrics. And so to be cognizant of the people that are taking care of the patients, what we don't want is that, something comes down from 5 different plans that ends up not looking. I mean, that's why we created common metrics, and so that there may be some tension at play for metrics from the outside.
It's great feedback. So, we're going to just review, actually, thinking about the comments.
So I thought, so a couple things. Since the last meeting, I sent out an assessment to the 6 commercial health plans, and I asked them to complete it in a really short time frame. And we have 2 of them in the room, and we're expecting the other four. I asked them to be here by 3, so it's just literally 3 o'clock right now, and I'm sure they'll wander in here in a moment, thinking that they're on the agenda at 3:15. And I'm gonna hand out the assessment. And for those of you on the phone, I will have to mail it to you after today's meeting. The purpose of the assessment was to do a couple of things. It was really to ask, I gave them a list, each of the health plans, a list of the measures that are appropriate for contracting with either medical groups or hospitals. And I asked them 2 questions. The questions were, do you use each of these measures to monitor and provide feedback reporting to medical groups, yes or no? And if the answer was yes, then give me a very rough estimate of how many of the group contracts that you have or hospital contracts do you include these measures for monitoring. And then the second question was same question, but only related to payment and incentive programs. So listing the measure, do you use this measure for payment purposes, and if so, what percentage of your contracts are really influenced or impacted by that? I want to emphasize that I told all of the health plans, here they come in mass. You guys are organized. So I want to emphasize that I did tell the plan because it was really a short time frame. You know, I wasn't expecting, they all have thousands of provider contracts, like literally thousands. And I wasn't expecting any of them to, you know, go through their files and literally count every contract and measure for every measure. I wanted to just get a kind of a rough sense. So, you know, I said, is it 5%, is it 50%, is it, what is it? Just to kind of give us a feel for it. So that's what the assessment is in front of you. I want to thank all of the health plans. Come up here, guys, you're on. So I just really want to thank them because I think they kind of busted their butts to get this assessment done for me in a short period of time, with enough time for me to compile it into one document so that you would have it. And what I thought I would do very quickly, one of the things that was attached in the mailing that went out for this meeting was it was a document called Use of Measures in Value-Based Contracting. And it literally lists the measures. For example, there are 15 measures in the measure set that are only recorded at a geographic level, and they are not intended for provider feedback reporting at a medical group level or contracting. Those are listed on the document that I sent you. There are also 3 measures related to cost that are just a macro level at what the state spends on healthcare. Those are also not appropriate for contracting. But there are 35 measures in the measure set that are appropriate for contracting with health plans, meaning a purchaser's contract with a health plan. There are 24 measures appropriate for contracting with medical groups or clinics. And there are 10, especially groups that have a primary care presence. You know, a lot of them are really focused on primary care. And then there are 10 measures related to hospital care that would be appropriate for hospital contracting. And those are all listed in the document, and they're actually also listed on the assessment that I handed around. And so then I asked these folks to join us today, and thank you all for being here at 3 o'clock on a Friday afternoon, on a beautiful Friday afternoon. Much appreciated. And I asked them, we're going to do introductions in just a minute, but I asked them to really talk about a few things. Lydia, come on up. You're down at that end. Yeah. So I asked them a couple of things. I set up the measures in the measure set that lend themselves to medical group or hospital reporting. You know, which do you commonly use? Not, you know, you can see for yourself what the answers are, but I just kind of wanted to talk about, why do you use them, kind of which ones why. For those that, and there's a lot of them that are not in use, when they're not commonly in use, why is that? And then, in their opinion, what are the biggest challenges to incorporating more measures from the common measure set into either feedback reporting or contracting? And so, I asked each of them to just take 5 or 6 minutes and go around the room and answer these questions. And then I thought we could just open it up for a conversation among all of us. And with that, let's just really quickly do introductions first again. David, you already introduced yourself, but you want to do it again?
Sure, especially for everyone else down here. I'm David Buchholz. I'm a general pediatrician from American Blue Cross. I'm a medical director, and actually I play all three roles that Rick was describing. I work on the provider side in terms of provider contracting and engineers for quality and risk adjustments on customers. I work on the customer side, helping to educate our larger employers on what value-based contracting is about, and all of that work, trying to get them moving towards value. And then I'm the medical director for Medicare Advantage, so I have a lot to do with STARS.
John?
John Preston, VP Network Strategy for Kaiser.
Good afternoon, I'm Jim Fitzpatrick with SIGNET here in Pacific Northwest. John Public, Medical Director for SIGNET Pacific Northwest.
I'm Lydia Bartholomew, family physician, senior medical director for Aetna for the Pacific Northwest, and I get to do everything Dave does, plus actually supervise all the UN and CM.
I'm Joe Bottolato, I'm Executive Medical Director of Provider Partnerships and Quality Region based in Portland. I have a 4-state footprint, so I do mostly value-based contracting with folks, and also some quality stuff, all of the quality stuff getting larger and larger and larger, so I'm trying to clone myself as needs. Happy to be here.
Good. Would it be helpful to you folks if we did just really quickly around the room and on the phone, please? That's what made me think we could go around the room. Why don't we start with Ken, since you just walked in?
Introductions?
Yeah.
Ken Jaslow, Vice President of Quality and Risk Adjustment at American Blue Cross.
Dale?
Dale Reisner, I'm a maternal fetal medicine doc, and I to represent Washington State Medical Association.
Laura Pennington, Healthcare Authority. Healthcare Authority.
Oh, Susan McDonald, KP Washington, Quality.
Kathy Lopi, I'm with the Department of Health. Marie Dunn, I am with the Quality and Safety Work at Public Health.
Yeah, I'm also Chief Medical Officer of the Healthcare Authority.
Nancy Gento from Washington Health Alliance.
Tony Smith, with Spokane Regional Health District. Good afternoon, Rick Rubin with One Health Board.
And we've got several people on the phone. I'm just going to introduce you, it's easier. Lori Derrick with Oregon Health Sciences University, Francis Goff with Molina Healthcare of Washington, Jennifer Graves from the State Hospital Association, Elia Moore with the Olympic Community of Health, and Marguerite Rowe with Seattle King County Public Health. So with that, I think we're going to start with John. I'm just going to ask you to kind of go around and take 5 minutes or 6, 7 minutes, whatever, and kind of talk through the gestalt of those questions up there from your perspective.
Again, for the record, I've been with Kaiser since December, so a lot of this information I have is from Susie's team. And Susie, feel free to jump in. I know that you were kind of at the beginning of this whole process and helped build it. I think from Kaiser's perspective, our network strategy, given our medical group model, is that we just don't have passive relationships with external providers. Our relationships tend to be relatively thoughtful and substantial when we do contract for services outside of our own delivery system. So I think when this whole program was coming together and Susie's participation, we did want to be a first adopter and set a precedent for participation. We use 17 of the measures in our commercial QIP, and I think what's unique about our QIP program is it's a pure quality-based incentive model. There's not a cost quality aspect that encumber it. So we do have a relatively pure play incentive program that's quality driven, and again, we use a relatively large set of the measures, being 17. We do have a hospital incentive program, which is a little bit more of a customized, select facility type of approach. And we do use 2 of the measures in the hospital incentive programs generally. And then on Medicare, our incentive model is really more STARS driven, CMS focus centric. As far as some of the questions around barriers and challenges, I haven't actually been in a situation where I've experienced our challenges. I don't know if you have anything to add.
Yeah, I would say probably this would be similar to other health plans, because KP Washington has our own and operated delivery system, easier access to data from our own medical records, as well as claims. And then with the health plan, so like the incentive plan, some of the measures have been more challenging because we have a more challenging, if you're going to hold people accountable, you want to give them monthly feedback. And so some of the measures we can't get easily, like blood pressure control or things like that. And so I think there's just the administrative data system challenges that make it hard. So in some ways, the contracted provider groups have fewer measures to deal with in our own and operated delivery system, just because we don't have an easy method, although we're really working hard to improve that. I would say that's just some of the challenge for our own. In implementation, you can implement more easily. You have many more levers when you've got your own delivery system and you got Epic and you got a lot of things that you can support. We try hard to support the contracted providers, but that's really more an implementation rather than whether it's the right measures to use or not. We just try to take a population approach and expect quality outcomes for all of the members that we serve, and then do the best we can to give information to our contracted providers. And we just frankly it's a little easier, or maybe sometimes a lot easier with their own delivery.
Yeah.
But the rest of you health plans deal with it all the time because you have more of that than we do.
Yeah, I think the dimension of us having a big medical group that also participates in all the reporting makes our program less of a health plan driven program, more of a peer-to-peer physician group type discussion.
Right.
So it ends up, I think as far as the implementation of the measures, it becomes more of a consultative peer-to-peer discussion. And we actually have a team that we send out twice a year as far as a consultative group, and it really is a physician-centric driven, doctor to doctor, and us living this measure set along with how we, work with them as a health plan.
Okay. So my thought was that we would hear from all the plans and then open it up. So David, do you want to go next?
Sure.
Mara?
We, actually, this really wasn't that hard to do, to fill out, to be honest, because even though we have thousands of contracts, the reality is we only have 6 contracts that are universally used across the state of Washington, at least, that sort of fit depending on the type of provider group. And then in terms of medical group, and then we have essentially 2 value-based hospital incentives. And there's only 2 because one is for all hospitals and the other one is for a very large hospital system that insists on being special. So in every case, the question that Susie did not ask us is, do we have any measures in any of our value-based contracts that aren't on the common measure set? And I can honestly say no. We particularly looked at the common measure set to make sure that we don't add some, even if the provider groups are asking us to add. Susie and Dan know that one group is specifically asking for AMR instead of MMA in terms of asthma measurement.
We agree with that.
Got it. We actually told the group at the last meeting that we were gonna actually consider changing that. Yeah.
So as I go through all of this stuff, typically the most limiting factor is that there are too many. I think when you look at our spreadsheet that we filled out, and there's a lot of commonality, but there's a lot that we sort of uniquely do, it's because there are too many. And so what we do is we work with and through our providers to sort of select what are they working on? What is the seeming like the most important? And in fact, even for reporting purposes, they're often telling us that if we try to give them all of the measures, they say it's way too many, we get lost in it, please don't do that. So we purposely don't provide all the measures.
And just to be clear, I don't think we've ever had an expectation that all measures would be used all the time in all contracts.
Yeah.
Right.
But just that when measures are used, that the measures would align with the specific measure in the common measure set.
Right,
Yeah.
and of course, as a health plan, we stick to we tend to stick to the NCQA, EVIS measures, and not so much of the homegrown measures. We report, even though you asked us to specifically say no on certain measures, which we did, we actually use the Medi-Cal criteria for yard utilization, for and those kinds of things, but we don't actually use your exact metrics, so we said no. But anyway, I think if there's going to be any movement towards more consolidation to spare the docs, is to figure out how to even limit the ones that are recommended for contracting from, I think it's 24 down to something much smaller.
Well, just as a side note, to put in a plug, nobody's really maintaining the Medi-Cal measure, and they haven't for years. And the measure that's approved for the common measure set was really a fairly rigorous process of looking at the measure used in Oregon, the Medi-Cal measure, and the measure used by Group Health, because they were really actively doing this. And we merged the two of them and have a much more robust measure that's been converted into ICD-10. So just a plug for the measure on the measure set. Okay. Anything else, David? Okay. Jim, you want to go next?
Sure, I'll kick off. Yeah, when I talked to Susie last week, I talked to her so that I could get to be on the road, and while he's a little jet lagged, probably, I'm glad to have our quality expert here with us. I think I would comment from Cigna's perspective, I mean, we're all trying to move, of course, from volume to value. As a health plan that's really 95% self-funded ASO, the PPO environment, it's pretty difficult to figure out how you're going to provide meaningful incentives, in terms of quality measurement to achieve these goals. We're going to give you some incentive or dollars to do that. So we do that. We have done it successfully with our collaborative accountable care model, we call it. We do pay a care coordination fee that has measurement for quality and performance. So we had, I think 3 years ago, 117 or so different quality metrics, way too many. We got a lot of feedback that was too many, and then with help, what's happening here in the market, and from our own national kind of views, we've pared down to, I think, something like 17 measures now. So I think my comments are really that we see the importance of being able to measure quality. We are incentivizing people to do it. In a self-funded ASO, it's difficult to make it meaningful, but we're getting some primary care sort of capitation rates that are running, $8 to $10 rates that are pretty meaningful to some folks on attributed members.
Just to expand on a couple of those points. So when we started building our value-based contracts about 5 years ago here in the Northwest, we had 1 5 years ago. We have 10 now, and I'll reiterate what Jim said about that. We had 113 people said that's way too many, so we said we're going to cut it down to 17, and our group said that's too many. And so, but really, actually, if you look at the way our categories, it's really 3 or 4 main categories: so CAD and diabetes, and so we try to convince them it's only 5, but it's 17. But we do have some of the challenges Dave said about some administrative versus clinical stuff, because we can't always get the information we need. We do report on ER utilization, affordable ER and hospital. I think we said no because ours aren't measured exactly like yours. And I'm going to use this excuse before Lydia gets the chance. In a 50-state plan, to try to have a different. I know you're saying, City, you don't want different, but just to use the same kind of aligned membership. So we use for affordable ER a list of diagnoses that we think can be better managed outside the emergency room, like sinusitis, headache, and some others. So it's probably not completely New York or California based, but it's a list that we use and it's a list that we communicate with our clients about. The other challenge we have with some of our partnerships is, since Cigna doesn't have giant penetration yet in this market, is that some of our measures, even though we have 17 that we measure, we hold them to it. They have to have a team of 30 for it to be qualified. So even for some of our contracts, the numerator and denominator decreases in those sets. So sometimes there's, 10 out of 17, it might be 8 calculator quality gate on. And some of these that we've heard the most about, and I don't mean to say this is what the Washington Health Alliance should do, things like cervical cancer screening, for example, some of these change in the time period since we've decided they're the right things to do, and the time frame and how many years, it gets so confusing for people. In a commercial plan, we won't look at stuff until it's 2 years old data, and a lot of our clients only been doing this for a year, or people come and go, and so they're dropped out at the end too. So some of these longer term measures it's hard to do right, so we just say it's hard to move the prevalence to it. And then back in my Kaiser days, years, we look at some of these things like cervical cancer screening, drive it up to 90%, and then they would fall off the list because we were doing so great, no one was then watching it, so then our performance was a little bit. So it is important while you're watching it to stay high, but the minute it's not being watched by anybody else, you can only focus on so many things at a time, and generally that's what they'll spend their performance. And I think that's where our provider partners say, we want to focus on certain things, and I think, I don't know if Davey said this too, is what do your other value-based contracts have? Let's try to at least line up most of those, because it took me a couple of years to realize that my partnerships here in town, if you're going to be successful in your population management strategy for your entire population, you're going to be successful in the Cigna population. So I can't expect you just Cigna a certain way. And so I think that's where we have limited our numbers to be kind of consistent with everybody else's. And I was surprised to see that, how many of them were aligned.
Lydia?
Alrighty. So, so we have a pool of measures, like everybody else, and we allow folks to select from that pool based on what they're working on and what their denominators are. And so most of our groups have somewhere between 5 and 8 metrics that they're working on. And then once a year, we give them all their data for all the metrics that we have, and that's our conversation about what's next year going to look like. So, so they get to change them to keep with whatever it is that they're working on, and at the same time, it's a small enough group that they can focus. One of the things that we've had to do with our measures is put in some, for lack of a better word, attribution qualifications, because practices frequently, groups complain that, the member who joined on December 1st is not a member they want to be measured on December 31st. So we do have provisions that say that they have to have been a member for, X, a year, 2 years, whatever. It varies a little bit, but we try to be sure that they've had kind of a fair chance at taking care of our issues. So we try to only use national measures because we're a national plan, so that's an issue with some of the metrics on your list. We do also divide the metrics. We have multiple quality programs that we run. So some of the metrics fall into our, basic PCMH, ACO, primary care sort of model. Some fall under utilization and some fall under quality. We also have different programs for hospitals. We have a quality program for OB/GYN. We have a quality program for behavioral health. So it also depends on which program that you're in, what metrics you're using. From our perspective, we want something that, getting the data is an issue. Other people have said that. Things that require chart review or submission from the providers are difficult. We have to, we also want something that has a real ROI, and that's an interesting beast to chase. It really depends on, how you look at it and what's your time frame and all those things, but that goes into our decision making. And then the issue between fully insured and self-insured, we can do anything we want with our own folks, but for our self-insured members who look to everybody else, just like Aetna members, we have to have permission from the plan owners to do these sorts of incentive programs and quality work. So that's kind of where we are. We've talked to everybody about having a value-based contract. Their contract is up for renewal. And we actually have goals that we've set as to how much of our business we're going to get into quality, a value-based contract over what time frame. And it's pretty impressive. We're actually doing really well in Washington. Not so well in Alaska, but it's Alaska. We're working on it.
Thank you. Joe?
Yeah, kind of an interesting number that are being thrown out. So I think 2 people mentioned they use 17 metrics for the, I think John said the QIP. We also use 17 for our QIP. It was interesting. So kind of similar to what Lydia was saying, we have 3 different quality programs. So standard HEDIS we align with about 28 of those, so that's pretty good. One of our challenges is really, since we have a 4-state region, like they say, medicine is local, and it certainly is. So oftentimes having certain conversations with a rural provider in Southeast Idaho or maybe even Utah is a different conversation than having it in Metro Portland and Metro Town. Just because of they're smaller communities, like there was an issue with the chlamydia screening measure. There was a clinic that said, Joey, why don't you go out there and talk with us about this because we don't agree with it. And I went out there and talked to them, and they said, well, a lot of the young women who we see here are, kids of physicians, and they don't want that information yet. It was confidentiality issues, and I actually had one physician say to me, well, we don't have to really worry about screening that here because we know that that's not an issue with our town. I actually had a physician tell me that. Anyway, so the whole point was maybe that was a little bit so different conversations with different groups. We have our total cost of care program. We only have 2 groups that are at downside risk, as most folks here know. Most groups are very averse to go to downside risk. And so, yeah, I think the overall alignment was pretty good. I think some of the struggles that have been mentioned are getting information back from the providers to the plan, especially supplemental information. Attribution is always an issue. Our attribution method is that the person has to have been seen twice within a 24-month period for them to be attributed to that provider. So, yeah, a lot of similar stuff, just different machinations of it.
Okay, and then finally, Michael Taylor from United Healthcare came in, so he.
Sorry, I'm a little late, y'all. I just moved from Florida about 7 months ago, so I'm still trying to get used to refills and stuff. Everything's really flat. I'm heading in the right direction. That's all. So anyway, my apologies. Thanks. And I did this role in the Southeast, so it's really great to hear what good things that are going out here are totally different than what's going on in Louisiana or Mississippi and things that we're doing in specific 4 states in the country versus what we're out here. So I'm over our accountable care strategies. Team Northwest, I have oversight of all of our ACOs, all of our value-based contracts. Our ACO, our experience is a little bit different, I think, than theirs. We have 90% of our self-funded business has adopted into the ACO funding, so we've had great success with it. In the beginning, it was probably about 10 to 20 in the first couple of years, but they see the value in it. Delta specifically came to us in Atlanta, obviously, wanting us to do even greater deals and narrow network around certain facilities because they saw the value in these programs. And my team was created because United is a really large company, we're the 6th largest company in the United States. So, we have these national platforms, and they really wanted our team to lean in with what's going on in these local communities. So our measures that we go out with, we have 35 in the ACO model. I'll give an example. So in South Florida, cesarean section rate is outrageous. And we have a Latino medical director there. She's like, it's part of the culture. That's just, it's a thing that it's ingrained. So they always wanted to include that metric, but that's not something we see out here. Similarly, we have outrageous pharmacy use in the Southeast. I mean, I can tell you growing up in Florida, if I didn't walk out with a bag of samples and a prescription, I didn't feel like I was treated. I thought and it's quite the opposite out here. And I mean, if you had people, the drug reps hosting lunches and giving out stuff, and out here, conversely, when I meet with large health systems, they were like, oh no, we don't allow that. So it's great to see how far ahead we are. But so we have a list of 35 measures in the ACO, and we always start out with, what are you already doing with your other payers? We don't want to come in and ask you to reinvent the wheel and start over. So we kind of run a prevalence report just to see the areas where they have opportunity. And a lot of them fall the same: diabetes, cervical screening, chlamydia. We always add in some hospital measures. Well, obviously, a lot of our spend is going to flow through the hospital. It's important that people are using the right point of care. You guys have done a great job. We just have overflowing ERs in the Southeast. Everybody uses that as a primary care due to mental health. They can get in and get out for free. But you guys seem to have really done a good job. Those are care centers and pathways, and we don't see that trend out here as much. But our team really collaborates and sets the metrics with each provider, and we don't compare them against market or any, because we don't care what goes on outside their walls. We want to help prop them up and make them, their members be healthier and have, better outcomes and better lives. So that's our strategy. We also have a hospital, PBC program, hospital performance-based contracting where we have about 17 measures. We also have a physician primary care incentive plan. Similarly, I'll give you an example on the physician side. We're an open access network. 90% of our members, people want choice. So it's kind of hard to bring those people back in and when they don't need referrals and so forth. But our model incents them in a way to make sure that they're using making sure they're using our lab of choice or making sure they're using ASD, participating ASDs and so forth. So we kind of reward them for those types of things in that program. So I was on a leadership call Tuesday. We have about $66 billion worth of our spend flowing through our value-based contracts as of right now in the year, and we are target, and we'll make it at $70 billion by the end of this year.
Do you know that number for Washington?
Well, heck, I didn't come prepared. I'll find out. I have it somewhere, but I'll get that out to you guys. One thing that's also great, I have oversight of some of the Medicaid contracting in the state of Washington has tasked us with adding some behavioral health measures. And so we're doing that now, and hopefully our broader scope will see that we've got to treat the whole body, and hopefully we'll be able to roll that out. I mean, this part controls a lot of things, so we're hoping that some of the conversations that are going on here in Washington, we're going to take back up to our national team and say, hey, maybe we should put this out there and see, add it in a measure.
So if you don't compare providers to any kind of benchmark, and if their performance, if you know their performance is really low compared to benchmark, how do you?
We negotiate with them in a stepped fashion. We usually do a 3-year term, because we know they're not going to get the lift overnight, especially a large health system. Smaller medical groups have the ability to pivot faster. So we set metrics. We say, all right, increase your diabetic screening by 1% in year 1, 1.5 in year 2. We don't want to set them up for, and we just want to help them get better. And we don't want to say, Dr. B down the street is doing a heck of a lot better than you are. That's not fair, because we don't know what their patient mix is, what their population, and every provider will tell you they have the sickest patients in the city. So that's what all of you say. We don't, it tends to get adversarial, so we don't want that outside noise. We really just want to help them have better outcomes. Our members, their patient works for everybody, and not just dictate, just help them get there. We have a suite of people that we surround our ACOs with. They have an ACO account manager that handles their day-to-day stuff. They have a dedicated roster person. If we don't have the physicians loaded correctly, we don't have the members attributed correctly, none of our financials are going to work out. We give them a clinical transformation consultant, a full-time dedicated person that leans in with them, goes out to medical groups, helps them kind of change clinical pathways, look at best practices from some of our other ACOs. We also have our healthcare economics team that's dedicated to them for any financial questions they have. We also have a national healthcare economics person if we need to elevate that. And then we have our market medical directors that we surround them, because it's a very expensive program for us, but we want to make these very successful and help everybody live the line.
So I have a question. It's interesting listening to the conversation, because it sounds like around the table, people either are giving practices, systems, the flexibility to choose their own metrics, or are saying, what we'll do is contract with you in a way that's similar to other value-based contracts you have. So if I take that to its natural conclusion, I think to myself, well, then there shouldn't be, what we hear from the practice community should be, this is hunky-dory, because I'm not being asked to do too many, report on too many, or tie too many to value-based contracting. So there's a real disconnect here. And I know we're not, we don't have Medicare in the mix at this point, but on the other hand, we've got all the major payers in the state around the same table. So where's the disconnect?
I think one disconnect, because we've just gone through this recently with some of our partners, is that even though we have contract-based quality groups through our accountable care organization, we still do collect unit data. We still make, you have to get that data from a lot of our groups, and that may be where some of you're collecting too much information or too much about it. So that's a broader data set that we request, but we don't feedback their performance.
So that's for NCQA accreditation purposes, right? But that would be the same,
Same stuff.
it would be the same stuff, right? I mean, more of it, from a reporting standpoint.
Yeah.
But it should be uniform because you're all collecting the same data.
Well, but for some of the measures, you can't get the data. So it's not just the data, because if you're trying to influence performance improvement, they want regular feedback, and NQA is once a year. So for some of the measures, it's really difficult to give them feedback in a meaningful way to drive action to improve. So that's getting into some of the detail, but that's why not all HEDIS measures, or even the whole list, are used in our own delivery system. We recognize it's easier for us, just like in KP Washington, we're tougher on our own provider groups. We expect them to perform better because they also have access to many more tools and information than most everybody else. So they need to perform higher, but the other ones, if everyone did have the same measure set, that would be useful, but very useful, and there's subsets of that, right?
I think there's a gap within our partners' organizations as well. The people in the room know what the contract is, and they know what the metrics are, and they know what they're working on, but that doesn't mean that every doc and every clinic has a clue.
Yeah.
In fact, I've had a couple of separate experiences. In one case where we signed a contract, and then I had a separate meeting with the medical director for quality for that organization, who had no idea that the contract was signed, that there were metrics, that any of that stuff had happened. And if she's the medical director for quality, that's not the person on the ground doing the work. And in a second organization, it turned out that they internally well, first of all, that all their doctors didn't know what contracts they had and what metrics they were measuring. So that was issue one. But issue two was internally for their own docs, they measured their success, or, their targets were completely not aligned at all with how any of us would do our targets, most likely. And so they were thinking, we're coming in saying, well, gosh, you guys aren't doing so well. And they'll go, what do you mean? We're fine. And it took a while to figure out that they were looking at it a completely different way. So I think there's a lot of communication misses that contribute to all of this.
And so what could fix that? What could address that?
Magic.
Beyond magic, what could?
Well, the provider in taking care of the patient doesn't think of you're primary, you're this, you're that, right? They're taking care of the patient. So at the front line level, taking care of patients, to me, ideal if you had one set of measures everyone agreed on, and that is what we all, and you don't have to think about what I have to think about for Primera versus someone else. I'm just thinking about cancer screening.
Right.
And everyone's going to organize around cancer screening, or the ones that we all know are really important. So I think picking and choosing, whatever, it just mixes people up. The frontline providers are not thinking of who gets money for what measure versus another health plan gets money for that.
They usually have no idea what plan their patients are on.
Nor should they. They're trying to take care of the patients that come in. You want to organize the work around the clinical care and the patients and the populations, as opposed to all these people that want money for this and that and the other, right? So.
But also to answer Dan's question, our contracts, we try to get our medical group contracts to be 3 years long. And we purposely don't want them all expiring at the same time. So that's why you could also start to hear that there's a lot more variation. Because it's going to take 3 years for that to change.
That's true.
Oh, right, good point, right.
One thing that we've seen is you have a strong physician champion in the organization, that people that want to speak to their peers, we've found that those folks, those ACOs are much more successful, and we have those here with our ACOs in Washington. They're always at our meetings, they're always at the table, and have their other clinical teams there. We differ a little bit, I think, from them. We don't actually, if they get into the measurement period with us, as any of our ACO providers do, and they're missing maybe 20 patients that need a go. We don't want their records. They just sign an attestation for us, because this is a partnership. We're trying to get beyond the fee-for-service thing. We just ask them to attest. It's a one pager, they sign it, we cut the check. So we're trying to really expand past that, just adversarial type. And like I mentioned earlier, in our negotiations here, and we're in the middle of one now, we really want to make it easy for them, as some of our competitors have, just picking the same measures as long as there's the same prevalence, so they're not having to reinvent the wheel for. And I've worked on your side of the table. I was at an independent hospital for 7 years, and I know you can't treat the same patient versus the United, so we really want that consistency and help better outcomes for everybody.
So a question, I'm asking for maybe a precise answer to an imprecise question, but somebody noted the sort of synergy around the number 17, and everybody kind of laughed and said, well, that's too many, and 0 is too few. You know, I'm curious, has there sort of been a sense that there should be some small number? You know, the concept that we were just talking about is, is there any sense of what a good number would be? Is it 2? Is it 7? I'm just curious if there's a collective sense of what the right number is.
I want to answer it by rewording it a different way. And I was in the Kaiser organization for many years, and I think everybody should be measuring and looking at everything. What you incent on and what people put their prioritized time on, and then how you get people to work on things is a different conversation. And I don't know what that number is, but I think, I meet with a lot of primary care doctors that have, dashboards in their clinic, they have 100-something things. They're working on, they're looking at it, but if there's only so many minutes in the day and they have to close 3 care gaps on typical cancer screening, that's probably where they're going to put their time and attention. So I think we have to figure out how you balance that. We're going to be a quality organization, and I think, and I got to give credit to the Kaiser people, which,
they've been doing it for a long time.
But they do it for a long time, but the thing that makes it work so well in that organization is the system does it for the physicians. I'm going to oversimplify that, but the system makes it more possible for the physician to be successful than probably any other organization I've seen. And one example I've used before, one of the reasons they're 5-star in Medicare is some of the things they had to be 5-star, they completely hardwired into the system when they would be successful in things like osteoporosis measures if somebody has a fracture. If there's a claim, referral to fracture claim, this doesn't happen. So the physician doesn't say, does my patient need this thing done today? The system does it for them. And bigger systems can be more successful. Now, we have ACO partnerships with IPAs and with systems, and our systems do better than the IPAs. Because I don't know, when I meet with one of my IPA leadership groups, I don't have an idea of what goes from their office to their quality person to 27 different clinics. My guess is not very much about what they have to be working on.
Yeah, so, I think what Lydia was saying really hit home where, we've got 6 different pairs around the table here, but that's 6 different systems. It's different ways of gathering information. It's 6 different systems that providers have to look at. I think one interesting thing that I tried to do with the providers I was talking to was, I asked them to throw away HEDIS measures, throw away our QIP measures, and I said, if Regents was going to evaluate you as a provider, what are some measures that you would want us to take a look at them and say, yep, if you're hitting all these out of the park, you're doing a great job as a provider. I got some really interesting answers. A lot of them were non-answers. And I said, just forget about the HEDIS. And what's interesting, though, is providers could not think beyond these measures. And it wasn't because they agreed with them. They were just so inundated with these measures time and time, and they couldn't think beyond that. And I think part of the issue is not just that there's so many systems, but to be honest, there's no personal investment, I believe, with frontline physicians in all these measures. In other words, what you were saying, John, you're talking about, there's 2 different conversations to have, because they should be looking at everything, like you said, but really what's important is what's really important to you to say, I know that if you evaluate me on this, and I pay attention to these, I know I'm going to be doing a good job as a provider. 2 different conversations, and so I think we need to get to the point, and the other part is, too, is that if you look at studies, it takes about maybe 10 to 15% of a provider's income to be placed at risk on the quality side, so that they really start paying attention to this stuff. And a lot of times in systems, maybe 2%, maybe 3%. It's not enough for them to really pay attention. The other part, too, is we give these systems for our TCC contracts, these large payments at the end of the year. How much of that goes to the providers? How much do they see? $1,000, maybe at the most. So if you say, look, we want you to be accountable for these 17 measures, they say, well, I'm looking at my check at the end of the year if I'm accountable. It's not that they don't think it's important. It's like I work my butt off to try to meet these, and get the system to meet these. At the end of the year, what do I get? And so I think we have to devise a system where, I think part of the issue here is that a lot of these measures were not designed by frontline physicians to say, for instance, the other thing too is the patients totally left out of the conversation, completely left out of the conversation. Like, we really want to know how a person's doing after orthopedic surgery, measure their functionality. You know, how are they able to go on a walk after their surgery? You know, are they able to do things that really matter to them in life? But we really don't take a hard enough look at those. And I think until we get to that point, I think we're going to be going around and around and around and about which measures are important and which are not. And I think it's going to get more to your point, John. You were saying there's two conversations. Everything should be looked at, but what is really critical for us to look at? What are they really truly invested in? And because they really want to be invested in the health of their patients. So what do those look like? What are those measures?
I just want to stop and see if there's anybody on the phone that has a question or a comment, and I apologize for not bringing you guys all in sooner, but anybody on the phone? Elia, Lori, Jennifer, Marguerite, Francis, any questions or comments?
This is Elia. I don't have any questions. It's kind, some of you are kind of far away. I don't know if it's the mics or whatnot, but a few of you are kind of harder to hear. But I'm tracking.
Okay.
You just have to use your big voice.
I think just to the question, you know, I just think humans in general, I would put a number on it in single digits, you know. I would say 6 to 10, and I think about the clusters that we all tend to go around, cancer screenings, diabetes. Cancer screenings and diabetes screenings. That, and then this behavioral health that we need to also account for, that we're, for the most part, we're not doing a good job at. So right there you have, you're getting double digits already, but I would say 6 to 10 is what.
And when you, I would argue that we have a primary care value-based contract in Tumwater Family Medicine, which is down around the healthcare authority. And even though we're one of the larger insurers in the state, there's only 7 of these measures they get to credibility on. It's the 3 diabetes, 3 cancers, and chlamydia. Everything else is not credible. So that's all they're measured on, is those 7 measures.
It's not credible. What does that mean?
In that they don't have enough patients.
Okay.
To actually have, you know, like ADHD measures.
Oh, yeah.
You have to be social network in order to have enough.
Figure it out.
Right.
Yeah.
So that
challenge
influence.
I think there's not enough measures the way we need people to do them. Both measures are binary. You can do it or you don't. And I think we should figure out a way to measure that behavior, not say if you do it on 70%, you're 70% better than the guy, you're better than the guy that did 50%. I mean, I think that's we measure performance. I mean, you did a certain number of things a certain number of times. And I don't know if 100% is perfect and 0% is the worst. And this is back like I said, either do quality or you don't do quality. We have to figure out a way to reward doing quality. And we measure it money.
Back to your question, we strive for 8 to 10. Yeah, we strive for 8 to 10 measures at United. If you, in the beginning when we were rolling out these, we were doing like maybe 13 or 14. So you have these health systems out there trying to hit so many widgets that they can't lean in and focus on and effectuate change. And generally, all of our contracts are 3 years. So we'll focus on certain measures, the low-hanging fruits in year 1 to make them successful, and then year 2, we'll, as those numbers come down, we'll work towards the other. But that's generally what we have better success with similar to Primera.
So I actually, thinking about it, I want to sort of maybe take the conversation to another level of measurement. And the point that she and actually folks at the University of Michigan have made is that, you know, so arbitrarily setting a target is potentially a mistake. And the example that she gave in the talk is, you know, you have let's say a 70-year-old gentleman who has a blood pressure of 150 over 90, right? So they would not be a target, and if you had a blood pressure measurement based on HEDIS, that person would not, you know, they'd be in the denominator, they wouldn't be in the numerator because they wouldn't be controlled. But they might have had a conversation with the patient, you know, they're already on 2 drugs, and they're thinking about adding a 3rd drug, and the 3rd drug has X, Y, Z side effects, and they have a conversation, the patient says, look, and they talk about the risks and benefits, the patient says, look, you know, I don't want to add that extra drug for these reasons, you know, I'm close to target, I'm not at target, and so forth. You know, so that patient, you know, gets managed according to what their preference is. That is, I think, by anybody's definition, high quality care. And then the other one I'll just put on the table, it has to do with unintended consequences, because we're talking about cervical cancer screening, where, now, and actually in the Alliance report that just came out with the waste calculator, where women are getting far too many PAPs.
Right.
Because, as long as you can just do the PAP sphere, don't worry about whether they need it or not, then you're gonna hit the metric. So how do you guys, I'm curious how people are beginning to think about that in.
Can I also add, so if it's 8 to 10, and the 8 to 10 from United Healthcare is not the same as Cigna, it's not the same as Premier, it's not the same as Regent, then that provider group may have 80, depending on who they contract with. And so how do we come together to say what metrics are important in our outcomes? And I, Dan and I have talked about this in the past with NTSC C-section rates. So now let's term single C-section rates. I always said there can't be a number. It has to be get rid of unsupported variation and come up with, and let nature come up with a number, because nobody knows what the right number is for certain things. Now you might be able to say there's a right number for diabetes, for an A1C, but there's a whole lot of these metrics that are much more nebulous than that. We start getting into mental health care, oh my gosh, So I think we need metrics. I think providers want the data just like you guys want the data, and they would like to be a part of the solution, but they can't function if they're overwhelmed with, different criteria from absolutely every group that they contract with. And, some places like Kaiser, you've got it all rolled into one, but.
Well, we do and we don't.
Sort of.
So I think everyone has this long list of measures, and there's way too many.
Yeah.
So we measure all the measures, but in front of the providers, actually, we narrowed it to 6 populations, 19 measures per focus. Because they can't focus on everything else. And they're the big populations, and they're not arbitrary. They're picked because they save lives and money. They're big populations. There used to be a lot of variation. It's important to improve diabetes. It's important, at least of those 6 populations. Most of them docs don't argue with, because they get that this makes a difference if, to reduce cardiovascular risk or whatever. There's many other measures. Pick some. So that's what we did, because it was just impossible to get everyone rallied around focus. And so we're trying to focus on big populations, including depression, just trying to cover. That's just one method. We're not going to make up other measures, because we're given a set of measures we all have to organize around, right? We all have that same list.
Yeah, but to answer Dan's question, I think that we're a health plan, not a health system, so we have to be able to see it in claims data.
Right.
And every conversation that we have about CPT2 codes and sort of building them to your EHRs, Epic can do it easily, but none of our Epic providers actually have built the CPT2s. You guys are at.
Right, you're right.
So that's a challenge. So we really have to, we don't have the resources to look at things that we can't measure through claims.
Well,
That's a big weakness. We totally get that.
Yeah.
Right.
I was thinking back to your comment, made me think about how much noise we're seeing because of differences in how measures are defined. So, same measure, but maybe each of you has a slightly different definition at practice level. And so I'm curious to understand that, right? How much?
Everyone's.
Yeah, well, is there variability, or is it?
No.
It's all.
So providers think there are. Even in the Quality Improvement Committee of the Washington Health Alliance, I had a discussion with one of the medical directors who swore the way Regents measures heat and Premier measures heat is different. And I could not convince her otherwise.
But we all have the same specs unless you make up your own measure.
Right,
So
right.
That's
why we focused on common national measures.
That is, right.
Right.
That's pretty funny.
So I'm curious that the subject of EHRs has come up in a couple of your comments and observations. And actually, Susie invited me to talk to her quality improvement group yesterday about electronic access to electronic clinical quality measures. And so I'm curious as to, that's starting to happen out there. EHRs are not quite as impenetrable as they used to be, and there's work being done in this state around that. I'd be curious to hear from some of the health plans whether that would be helpful. You talked about how helpful that is within the system, but any comments on sort of is that a big barrier? Would reducing that barrier be helpful? Just thoughts?
We require you, group have an EHR to be part of our, quality-based CAC program, or ADO programs, because we have to be able to extract that information, so that's just a start.
Oh, you only, okay, gotcha. Yeah.
Certainly, we work with Health Information Exchange in
Speak up.
Alaska, and it's been really important to everything we do in Alaska.
I mean, ideally, our whole country would have the same system. Oh, come on. Nirvana, that everyone would have those systems. Of course, there's many practices that couldn't afford it, but wouldn't that be cool? And so all the data is just there.
Or maybe all the systems that they have would actually use the same standards.
Yeah.
They're never going to have all the same systems, but actually they could have.
Or a system
Adoption
that
of
somehow we could all pull data so we can, yeah.
Before we, when the conversation about how many should we have, it should be the same one, I come up at least twice, and I know I've said these many times about attribution models, about defining attribution models. We all use the same attribution model, that would be at least a little tighter on the
Something I don't think the state of Washington, or the Commonwealth of Massachusetts, I think did a really great job of having one common attribution model. One of the advantages to it is that if you have a preventive visit with a PCP, that trumps almost everything else in terms of who you attribute to.
So it's uniform across all payers then in terms of
Massachusetts.
and was that done through statute or how did they do that?
I don't know. I can share with you the papers around it, but
Yeah.
only in the last few years, but I think that's how Massachusetts got so far along in value-based contracting.
They also,
They started there.
do they also in Massachusetts have, because I remember at one point, if you looked at the top performers in MCQA, there were a lot from Massachusetts. And when you went back to talk to one of the groups, they said, everybody does this. That was a long time ago, so you probably have more information, but I just wondered if there's any state where this, the measures outside of the long list is more common. Because they said they didn't think they were doing anything special, like for wellness. I don't remember what it was, but they said it's just in the culture that everybody works on these. I thought that was interesting, and that would be ideally how we could get to, that we're all, right, we're all trying to get to the performance in the same way, so that individual providers don't have to be thinking about differences. I don't know how you do this, and I think that's what your goal was in establishing it to begin with, right? We clearly have a lot of variation. I don't know what you guys think of that, or other places of this formula, or those of you that have insurance, you're across states. Like some states do better than others?
Yeah, for us, Washington does the best.
Okay.
And I think part of the reason is that there's larger systems up here. In Utah, there's a lot of IPAs, and as John mentioned, you have to get information back from those people, those representatives, we're working with larger systems. What I was going to go back to was the comment about EHRs. I think that one of the things I think we need to that we're taking a stronger look at, and I think it would be quite helpful for other systems, is shared decision making. I know that that's kind of a talk of the town lately, and it really should be because we're a lot more patient-centric. I was talking with a CMO of one of the groups in Oregon, and I asked him about that. I said, do you use this as part of the culture of the clinic? And he's like, well, anything that we do must, flow through the EHR. If it doesn't flow through the EHR, the providers have to go on and log on a different system, or even if somebody else that's not a provider has to go on and log on a different system, that's just a whole different work stream. And so part of the struggle is when something is implemented, does it flow through the EHR? Since there's still many, most of them most groups we talk to use Epic, but still there's a lot of different ones out there. So unless it's almost like if it doesn't flow through there and it's kind of a smooth part of the workflow for that provider, it's just really hard to implement that. And that's one of the tools that would be great. But he said, we've had the discussions, but it was just kind of a non-starter because we couldn't figure out how to integrate it into the EHR. That's critical. That's a critical piece of taking care of a patient.
I've been listening with a lot of interest, and I think it's remarkable, the openness of the conversation and the collaboration. I think it's really terrific. And I mean, my question is, for the health plan leaders in the room, do you have a business interest in continuing the dialogue for simplification and more consistency around attribution models and that sort of work? Would that be something you would engage in a little deeper level that would benefit you all? Couple of yeses I hear.
I would say yes, but take it one step further on the attribution model, because I think sometimes things are timing and we're coming to a place where we may be able to do things we haven't been able to do in the past.
Yeah.
So when you bring up assignment, which is different than attribution, or picking a PCP as part of your plan so that we can say, this is, the doctor usually knows who the patient is, the patient usually knows who the doctor is, but we don't connect those two dots very well. We have a lot of clients when we're talking about how do we improve the quality measures for their population. We talk about if they have patient assignment, then they can outreach in a greater way. I've only seen them, so that's the only time I can outreach. They say, yeah, but we just don't want to force people to pick a PCP. I mean, but I think we just have to continue the same mantra, what it means to have a physician, and that physician can take care of you. And so I think maybe we'll all get kind of on the same direction on it. It'll make some momentum. But then people go, well, the 90s, and then they keep diverting to that.
And undoubtedly, John, it'll be like anything. You know, it's incremental. It's a few steps forward, and you know, even if it were a few steps forward in the right direction of some greater consistency, then we made progress, right?
So for a long time, we're going to need that attribution logic. We can't get our employers in Washington to buy a product that requires a PCP selection.
I know. David, we feel that pain too.
United, we don't get a lot of heartburn around attribution or attribution model difference. I think it's last primary care, same within 2 years or last one written, because most of the people on commercial plans tend to stay with their primary care in totality. I mean, they may move to another payer, and when they question us about attribution, I usually have a room around this size. I said, okay, who's changed their primary care? Unless you've moved, changed plans, or your doctor has retired, raise your hand if you've changed your primary care in the last 2 years. And usually I'm the only one located. So, I mean, we just don't need to get that as a heartburn.
So you know, the Alliance, we spent years developing our attribution model, and we have more than one. Tons of community input, a lot of meetings with providers and plans. And we have 3 attribution methods, and we don't get heartburn about any of them. So we have a PCP attribution method that's primarily related to prevention types of measures. And then we have a team attribution method for measures that relate to chronic disease. So if you're a patient with diabetes and you see an endocrinologist and a primary care doc, both of those providers will get you will be associated with both of those providers for purposes of counting performance. And then we have an RX method, which is used for things like, you know, generic prescribing rates, and it's just, you're just distributed to the person who wrote the prescription. So those are the 3 methods we've been using for 10 years, and they've adopted them in other states, other quality collaboratives or APCDs in other states have adopted our attribution method. We don't ever get any pushback from those, from anybody. And it's all on our website, and we talk about them, and people ask about them, and I think
Attribution to pay.
Right. No. But none of them are getting paid. I mean, none of them have, as you all just said yourself, you're tiny fractions of practices, and the dollar amounts aren't big, and they don't always flow to the provider. They often stay at an organizational level, so either the upside or the downside. So, you know, I just wonder how, even in value-based contracting, how much individual providers are really impacted by any of these value-based payment contracts. I know they're impacted by performance monitoring and feedback reports, because they see dashboards and meetings, but I think it's pretty limited in terms of the individual doc and how impacted they are by these value-based contracts and the measures in them.
I think one of the things that we saw was we were looking at our behavioral health program and everything around opioids, and I think one of the things that really gets the attention of providers is letting them know that they're actually not doing patients harm. So when we would bring out a list of patients, when we'd meet with a clinic or a group, we'd say, you know, these are all of your patients on opioids who are on, 90, I mean, these are great, or, when they see that information, they're often blown away, and they just like, oh, I mean, they feel horrible. And so I think those are the types of things that really get their attention. And if we can somehow come up with measures that really impact people sort of viscerally like that, they're going to, and the results in the 6 months after that, their prescribing rate goes down pretty dramatically. So if we can somehow come up with measures that really sort of impact them in that way, I think that's.
We just approved a measure that's basically that measure for the common measure.
Yeah, that kind of stuff gets their attention, for sure.
Yeah, great conversation. Are there any other comments either in the room or on the phone?
I really appreciate you setting this conversation up and inviting these folks to come, and I really appreciate your candor. This was incredibly informative. This was a great conversation. So thank you for scheduling, and thank all of you for participating.
Well, and I echo what you say. I really appreciate people making the time late on a Friday afternoon. I do want to just follow up on Nancy's question about a business interest, and I'm wondering if it strikes me that this has been such a rich conversation with so many good ideas, and actually even in some respects a consensus or in a general way, if it isn't worth trying to reconvene and structure sort of the conversation so that we could take it a little bit further, maybe with the benefit, we could look at some of the work that's been done in Massachusetts, and see if we couldn't, through creating this table, maybe do something that is benefits the plan sitting around the table as well as the greater provider community. And I'm wondering if people would be willing to engage further in conversation, and not on a Friday afternoon.
Yes. Not on a Friday. I told them no more Fridays for beer and pretzels. So I need to get a little more specific because that's a little too big for me. So because I'm the one that we have to organize. So my question is, what I heard, and I want to check to see that this is right, is that there's general interest in continuing a dialogue around two things. So I heard, keep measuring a lot of stuff, but can we see if we can get to a smaller number, somewhere like 6 to 10, that we really agree upon prioritizing for the purpose of contracting in particular. That's number one. And then the second area that we could try and get agreement around is on the attribution method. So those two things. Did I hear that right? Am I making that up? Or so not necessarily going, taking the common measure set and giving the heave-ho to, 40 measures. We always need to keep looking at the measure set, but keep the measure set as is, but picking a few to prioritize for these purposes, and then the attribution. I'm looking down at you guys.
I think the last one is a little bit, that may not be the right way to look at it, is this is my limited understanding by heat, is if we do 6 or so, maybe there should be some kind of cycle every few years where you sunset one, maybe bring another one in. I mean, build some kind of a cycle into it. So it might not be 6 forever. It might be these 6 for a few years, and we drop one or add one. Just what's important to look at.
I like 5-star. Now, they take Bill 41 and pick 9, right?
Not to complicate anything, I am a general pediatrician, and we do have pediatric single specialty practices.
Yes.
So you almost have to think about a set for pediatrics or a set
for OB and a set for.
Well, then,
Right.
remember, he is They see this as mostly primary care, and we as a health plan are moving towards probably MIPS, looking again, as our source for single specialty value-based contracting. That's what we did with an anesthesia value-based contract recently. So maybe that's something else that this group can eventually start to evolve to, start to think about the specialties and what we can get them as individuals. Right.
Well,
I would just say that I think that is a great concept because, you know, God bless the poor family medicine docs that cover absolutely everything. And so, you know, are they responsible for all 50? What number are we at? 57? So honing in on what might be core. And then for the cardiologists, obviously they got a set of stuff that apply to them and they don't have to. Right. Right. So that would make a lot more sense. And I do think that there's ways to overcome, if you came up with common single way of attribution, for instance, but there are ways that these EMRs could put that someplace and they could all have an external link to that. It would be an easy way for them to be on the same page. It would be costing like zero extra IT money. And I think the providers would have enough, you know, I'm going to say not just docs. I mean, we have Midwest, we have PAs, we have lots of other people that are providing care, primary care and specialty care, that would be able to understand this in a better way and would be also able to look at it for what I think what everybody in the room cares about, which is best outcomes, you know, value-based, best outcomes, best cost, and patient-centric. And in order to do that, you got to have everybody working together.
I think there's huge benefit. If you can narrow the scope to 6 to 10, training, communication, outreach, you know, all those things suddenly become less difficult. You're extracting data from the EHRs, focusing on smaller sets. Even if it's a rotating model like you talked about, where you know you have some organized plan for adding and sunsetting, I think you would see a lot of opportunities to reduce the friction, and again to help people figure out how to turn that into standard work. And that's what I hear all the time from the practice. They want to work, and if they can standardize across some different systems, I think you would all benefit. I think you would find it easier to work with your partners, and you would get better data back. And so I think it'd be a win-win.
Great. Kathy?
I was just also thinking about hardwiring EMRs too. I mean, if you get Epic to do that, then it's done for all the Epic customers in the state if everybody's kind of focused on the same thing.
Yeah. Well, and the whole world of FHIR and APIs is about moving from gigantic data sets to querying for discrete questions and getting discrete answers back. So if you were able to get to a point where you were looking for a more limited set of data, the world of technology is really targeting that right now. That's where there's a lot of emphasis on trying to deploy FHIR and APIs. And a lot of the HR guys are moving in that direction too. So it would be very consistent.
So I do want to just ask to see if there's any public comment, and I know we have some. We have public in the room, and also we might on the phone. I don't know what we've got on the phone, but what are we going to ask? Ladies and gentlemen.
No, just very interesting conversation, and I don't have the information in front to see where those common areas were, but it seems like, I mean, just understanding that if someone has less that they're trying to truly focus on, there's overlap, you're going to see improvement in those areas. And then each group can have other ones that they're focused on as well. So thank you for the opportunity to be here and learn.
I'll just stand up so you can hear. Again, Bob Fern, State Medical Association, Carol Eisner, and first off, the Medical Association is very appreciative of the hard work that you put in on this committee over the years, and to Dr. Eisner for the commitment to this work. Just 3 key concerns that I'd call out. One is, I think, very well acknowledged is the issue of administrative burden that results for everybody in having this wide variation of range of measures that are in play. And by extension, some of the related components of attribution methodology, which again also feeds into the complexity of trying to accomplish this work. Second, if a larger goal is the migration to value-based payment models, I think we're going to be struggling with this. Certainly very large integrated systems are going to be far ahead of the curve on this thing, but it certainly leaves the small to mid-sized practices in fee-for-service models because they just simply won't be able to conduct the kind of work that you're asking for. So it's essential that we come up with some way to try to simplify this so that they can participate meaningfully in those models. Thirdly, this again is a fine local solution, but again, if we walk in the shoes of the providers, certainly we have to recognize the fact that MIPS and Medicare and MACRA are realities that they have to wrestle with going forward. Medicare Advantage plans and the star ratings are certainly all part of the provider's reality. So again, we need to make sure that we think beyond that those are very real factors that are impinging on practices. Bottom line is, I think certainly as we craft some solutions going forward, they need to be realistically workable for the providers and for the health plans. These need to be win-win scenarios going forward. You know, and as this, you know, to make this really concrete, as this assessment is created, we have come up with the core measure set. I think that's an excellent beginning. And certainly would, you know, as Susie says, we don't want to just give the heave-ho, I think was the term about, to selected measures, but maybe within that core there is an essential core. And it should seem a fairly simple process to say, okay, if, you know, earning platform, which ones do you really, really, really need to have and are realistic? So it sounds doable. And again, I'll just certainly encourage you to continue your work. And I'll be watching from the peanut gallery.
Thank you. Thanks a lot. And I don't know, is there any public comment on the film? So good.
Should we call it a Friday afternoon and a sunny one and say thank you all and stand adjourned? Thank you very much. Welcome here, Michael.